Thank you so much for that lovely introduction, and thank you all for allowing me to be here with you this afternoon to discuss a topic that is near and dear to my heart, the management of the patient with dysregulated glycemic control. In particular, we're going to focus these next 20-some minutes on a discussion of patient with type 2 diabetes. And in particular, we're going to discuss a physiologic approach to treating said patient. We're going to discuss a pragmatic approach to basal insulin administration and delivery to our adult patients with type 2 diabetes. So we'll begin by discussing the practical barriers to insulin initiation. We'll move on to discuss the data and recommendations pertaining to basal insulin selection, administration, and titration. We'll discuss basal-supported oral therapy, BOT, and we'll finish by discussing evidence regarding safety and appropriate selection and use of basal insulin to clinical scenarios. So first, let's start with a case study. Let's discuss Mr. Rajeev. Mr. Rajeev is a 48-year-old gentleman. He smokes and was diagnosed with type 2 diabetes 6 years ago. His chief complaints in today's office visit are that of a history of early fatigue for the past 1 month, existing on a body of persistent malaise over the preceding several months. He works as a business manager in a renowned MNC and has a mostly sedentary lifestyle due to the demands of his work. On physical examination, we see that he is overweight with a BMI of 28.7. His blood pressure is elevated at 110/70. His blood pressure is still good at 110/70. His heart rate also within normal limits at 78, and it is regular. And the remainder of his systemic exam is normal as well. In terms of laboratory analysis, we have before you his glycemic control parameters, which actually failed to reveal glycemic control. His A1C is elevated at 8.6%, his fasting is 220 milligrams per deciliter, and his 2-hour postprandial blood sugar is elevated as well at 280 milligrams per deciliter. That being said, he still at this point does not manifest renal dysfunction with normal BUN, serum creatinine values, an estimated GFR at 95, and a urine analysis that is negative for microalbumin. His echo reveals an ejection fraction of 65%, and he has a normal fundoscopic exam in the office. In terms of current treatment, he's on triple oral therapy, on metformin 1 gram twice daily, the sulfonylurea glimepiride 2 milligrams twice daily, and the DPP-4 inhibitor sitagliptin 100 milligrams daily. Yet we note that Mr. Rajeev is not at goal. He's not under glycemic control. He's on maximally dosed just about 3 medications. His A1C is 8.6%. He's had type 2 diabetes for greater than 5 years. We really need to begin to think in a more physiologic approach, and rather than going for a 4th, a 5th, a 6th oral entity, let's consider a more physiologic approach of hormone replacement therapy for Mr. Rajeev. The historic algorithm of treatment for type 2 diabetes is one that begins with therapeutic lifestyle changes, evaluating the patient for modifications in their diet, in their exercise, and perhaps in losing weight. When that is not enough, and more often than not, it is not enough to achieve glycemic control, we move on to pharmacotherapy. With pharmacotherapy, we classically begin with oral agents first. The sensitizers, such as metformin and thiazolidinediones, moving on to secretagogues like sulfonylurea. We also have novel classes of medications, the incretin family of therapeutics with DPP-4s and GLP-1s, and we have SGLT2s. And yet, at the end of the day, we still have the oldest, the original medication for treating diabetes, hormone replacement therapy, insulin therapy. Really considered to be the dessert therapeutic. Why? Because we save the best for last. And we know that no matter what degree of glycemic control our patients require, that insulin will help us get to goal. Well, life is too short, my friends, to save dessert for last all the time. Carpe diem, seize the day, eat dessert first, and perhaps we should consider a more physiologic, appropriate, safe, and effective way to obtain and maintain glycemic control earlier rather than later in the lifespan of our patients. We know that our patients with type 2 diabetes make insulin. They are not overtly or objectively insulin deficient as a patient with autoimmune diabetes is, but they do become insulinopenic, at least in the relative construct. By definition, when you see hyperglycemia, the etiology is not enough insulin on board to get the job done, whether it's an absolute lack of insulin or a relative lack of insulin. So when we see our patients, adults with type 2 diabetes, that have had a duration of disease for 5 years or greater, that have been on 2 to 3 oral agents at maximum dosages, and still have elevated A1Cs to be defined as 8 or higher, these are biochemical signs of insulinopenia. When you see a patient who presents with the poly-Ps of the disease, polyuria, polydipsia, polyphagia, unintentional weight loss, that is insulinopenia or glucose toxicity or both. Fortunately, you don't need to decide because both are very well treated with hormone replacement therapy, insulin therapy, at least for the time being. At diagnosis, our patients are at 50% beta cell loss. Every year thereafter, there's an additional 4 to 7% beta cell loss. At the point that our patients are at 25% beta cell function, they're going to require basal and bolus insulin therapy. We should intervene on behalf of our patient sooner rather than later to assess their glycemic control and help get them to goal sooner rather than later. And we can do that in a physiologic way by initiating hormone replacement therapy with an ambassador insulin. What do I mean by an ambassador insulin? An insulin that speaks well on behalf of the class, that is kind, that is gentle, that is easy, that is convenient. Ideally, that can be administered once daily at the time of day that is most convenient for our patients. Basal insulin is not BIDS therapy. Bedtime insulin, daytime sulfonylurea. With a true basal insulin, yes, you dose once a day, and more frequently than not, you pick one time a day and stick with that time of day. So if your patients have a preference for morning delivery of their basal insulin, let them do it in the mornings. Also, basal insulin is kind, it is gentle, it is associated with lower rates of hypoglycemia than other forms of insulin, such as premix, either first or second generation co-formulation premixes, and is associated with less weight gain and less incidence of hypoglycemias than mealtime insulin. So as we just had a robust discussion immediately preceding this, really the talk is, how do we get our patients to goal with diabetes? And I think the underlying message is to put the numbers to one side and to try to bring our patients to as close to normal glycemic control as is safely possible for them. That means without undue risk of hypoglycemia. And if it means that you have to have your patient at 7.5% to minimize the hypoglycemia, if it means that you can get them to 6.5% or even less with sensitizers, then that is wonderful. Let us achieve that. Good glycemic control. Analogous to treating patients with hypertension to goal, patients with dyslipidemia to goal, patients with an elevated TSH to goal. Let us treat our patients with elevated blood sugars to goal. We know that with oral therapy, fasting hyperglycemia dominates, so let us fix fasting first, and the most physiologic approach to do that is with the administration of a once daily basal insulin. And the beauty of basal insulin is that it can be pleiotropic in its effects, especially when started sooner rather than later, earlier on in the onset of diabetes. We actually find that by giving basal insulin, you confer a degree of beta cell rest to the patient, such that you are giving them an 8 to 10 hour window overnight, if your basal insulin is titrated appropriately, in which it is the exogenous insulin that's putting the check on hepatic glucose output so that the endogenous beta cell population can make insulin but can store it in secretory vesicles to be delivered in the course of the waking hours in response to meals, which is why administration of a basal insulin, yes, lowers the fasting, but you also see a reduction of the postprandial as well. That is the indirect effect of basal insulin, which helps support the beta cells in their continued ability to make endogenous insulin. And don't just listen to me. According to my friend and colleague Matt Riddell, after 2 to 3 oral agent failures, the major contributor is fasting hyperglycemia. Let us fix fasting first. Strict control of fasting blood sugar with Insulin Glargine is effective to control some PPGs, especially when started sooner rather than later. Lancet itself says, with entry of Glargine, the basal-only therapy in combination with orals is established as a first-line, physiologic, safe, effective way to treat hyperglycemia and bring our patients to goal. And this is just a suggestion of some of the studies that have looked at insulin glargine as a once daily basal insulin in combination with oral agents in terms of effectively bringing our patients with elevated A1C to goal. The benefits of early basal and oral therapy are pleiotropic. We can modify the course of the disease. This is capable of restoring residual beta cell function in the short term, modifying the basis for a better response to different maintenance therapies. Early basal insulin add-on is associated with low risk of hypos and weight gain and is safe from increased cardiovascular risk in an enriched population. In addition, early insulin attenuates the risk of microvascular outcomes in patients with a baseline A1C level of greater than 6.4%. Global recommendations. I know we just talked about recommendations and which ones we should choose to adapt, but please entertain the recommendations from these global medical organizations who are 100% invested, dedicated, and devoted to glycemic control in our patients. American Diabetes Association. Basal insulin is the most convenient insulin to initiate therapy with. ACE, the American Association of Clinical Endocrinologists. Therapy with a long-acting basal insulin should be the initial choice in most cases. And IDF, for primary care, basal insulin should be the preferred insulin at initiation. Can we start with premix insulin, either a first-generation classic premix or a second-generation co-formulation premix? Of course, in medicine, we have multiple options, and there are many answers, not necessarily wrong per se, but there might be some that are more right than others. Let's look at insulin glargine versus premix in terms of glycemic control. There was demonstrated to be a favorable effect of insulin glargine and orals over premix and orals with respect to A1C without nocturnal hypos, A1C reduction in general, fasting plasma glucose reduction, target fasting plasma glucose attainment, and hemoglobin A1C target levels. There were lower numbers of symptomatic and nocturnal hypoglycemic events in the glargine group as opposed to the premix group. In terms of weight gain, there was a lower mean body weight gain in patients receiving insulin glargine and orals versus premix and orals. There was greater satisfaction of life with the glargine group over NPH. And in terms of safety, there was no significant difference. At the end of the day, we would like to achieve glycemic control as close to normal as possible without undue risk of hypoglycemia, using as physiologic an approach as possible. One of the ways we can achieve that is with a basal insulin. And if our medical organizations are concerned about the ramifications of hypoglycemia, let us focus on the individualized hypoglycemic events happening in our patients and what medications those might be associated with. When you have the ability to start a physiologic medication like a basal insulin, titrate individually to goal fasting blood sugar, there are fewer episodes of hypo than with a premix, where you really are condemning your patient to eat to feed the insulin, and you are deciding either consciously or subconsciously to allow the patient to live with a degree of permissive hyperglycemia or experience persistent hypoglycemia. And as we just had a robust discussion prior to this conversation, we want to avoid hypos as best as possible. The INITIATE study shows that patients have reduction in fasting blood sugars, and in addition, when started early on with basal insulin, we can see reductions in postprandial blood sugars as well. And of course, as we're trying to minimize hypoglycemia, please note that there were fewer than half the episodes of hypoglycemia in the glargine group versus premix, and less weight gain with glargine than premix as well. And this is another slide that describes those studies, with 16% of patients experiencing hypoglycemia in the glargine group versus 43% of patients in the premixed insulin group experiencing hypo, less incidence of weight gain in glargine versus premix, and a lower daily dose of insulin with glargine as opposed to premix as well. Let's now look at the efficacy and safety of once daily IDeg aspart, a second generation premix, compared with once daily glargine. Both groups of patients using oral agents, uncontrolled type 2 diabetes patients. The results over 52 weeks reveal similar A1C reduction in both groups, glargine and the IDeg aspart, but numerically better fasting plasma glucose reduction with glargine. There was also a greater mean total daily insulin dose with IDeg aspart versus glargine at both week 26 and week 52. In terms of safety and efficacy of IDeg compared to Glargine in our uncontrolled type 2 diabetic patients, as you can see from the graph here, there was an 86% higher rate of hypoglycemic events with IDeg in blue compared to Glargine in gray. There was, however, nocturnal confirmed hypoglycemia that was higher with the insulin Glargine group. In terms of body weight changes, there was a greater mean increase in body weight with the IDeg group compared to the insulin Glargine group. For initiating insulin therapy with premixes, both first generation and second generation co-formulations, they have an unpredictable action profile, hence higher glycemic variability. There's higher insulin dose, hypoglycemia, and weight gain for similar glycemic control with premix insulin, and we know we want to avoid that. And inability to titrate the individual components in premix is really the entity that restricts us and condemns us to have the patient eat to feed the insulin in a reactive way rather than treating the blood sugars in a safe and proactive way. Let's talk about the ORIGIN trial. The ORIGIN trial is a trial looking at adults with type 2 diabetes and even pre-diabetes. Early in the onset of diabetes, obviously very early in terms of the pre-diabetic population, which comprised 12% of the total population, and we see that meaningful institution of basal insulin, in this case insulin Glargine, over a mean follow-up period of 6.2 years was associated with no increased risk of cardiovascular disease, no increased risk of malignancy, but excellent glycemic control and empowerment and improvement in endogenous beta cell function, so that there was actually a significantly decreased rate to conversion of pre-diabetes to type 2 diabetes in this trial. And we see sustained A1C reductions throughout the trial. Here we discuss that in terms of effects on cardiovascular risk and cancer risk, Glargine is neutral, but Glargine may delay progression to overt type 2 diabetes when used very early on. In pre-diabetes, patients with impaired fasting glucose and impaired glucose tolerance, there was a statistically significant hazard ratio, 0.72, indicating delay of conversion to overt diabetes. So if we want to start insulin therapy as hormone replacement therapy in order to bring the patient closer to goal, close to as normal glycemic control as possible without undue risk of hypoglycemia, what is the appropriate starting dose of this physiologic insulin? In brief, how does one start a patient on Glargine? Again, this is not our grandfather's therapy. This is not BIDS therapy. This is not bedtime insulin, daytime sulfonylurea, where you start NPH 10 units at bedtime. And that was mandated because NPH had a half-life of anywhere from 8 to 12 hours. So you dosed it at bedtime to achieve reductions in fasting blood sugar. But basal insulin, Glargine, is once daily. You can dose it once every 24 hours. You can dose it in the morning, you can dose it at noon, you can dose it at night, per your patient's preference and convenience. And we do not need to start on 10 units. In fact, the initial starting dose, the point of direction for us, is dependent on two entities. What the blood sugar level is at presentation is defined by hemoglobin A1C and the patient's body weight. So taking into consideration patients across a wide variety of weights in kilograms, we take that into consideration. We also take into consideration their entrant A1C at the point we consider hormone replacement therapy starting a basal insulin. The line in the sand is drawn at 9% A1C. If you have a patient with an A1C of 9% or higher, please consider starting your basal insulin at 0.3 units per kilo per day. This remains a conservative starting point, as Julio Rosenstock et al. And a variety of other studies have safely and repeatedly demonstrated the majority of adult patients with type 2 diabetes require basal insulin dose of at least 0.5 units per kilo per day, if not up to 0.65 or even 0.75 units per kilo per day. If your patient has an entrant A1C at time initiation of basal insulin less than 9%, then you can consider starting them at 0.2 units per kilo per day. So with a 60 kilogram patient, A1C greater than 9%, that would be a start at 18 units as opposed to 10. And even if the A1C were less than 9%, you start at 0.2 units per kilo per day, that would be 12 units, still greater than 10. So for Rajeev, we advise him to quit smoking, engage in moderate physical exercise, and know that that does not count getting up from the chair and cheering for your favorite team in the IPL. That means actually getting out there and doing something. And we're going to prescribe him 18 units of Insulin Glargine U100. 3-month follow-up, his A1C has been reduced to 7.7%, fasting at 140, postprandial at 200. These numbers are good, but not great. So what is the next step? We still need to achieve triple F therapy, fixed fasting first. We can do more here. Again, please recall that typical physiologic dosing point of basal insulin is about 0.5 units per kilo per day. Recall that frustrations may arise from unrealistic expectations. So if you're going to start your patient on 10 units a day, please let them know in advance that you're going to be titrating for quite some time to get to their goal dose. If not, by the time that several months passed and they're still at 10 units and do not see a favorable response in their glycemic control, they'll become quite frustrated with you, with the medication, and with the process. And we don't want that. Optimized titration can indeed lead to effective glycemic control. Initiation is only half the battle. Titration is the continuation of the war against dysregulated hyperglycemia. It is not enough to start insulin. We must continue to titrate it. And we do so again on an individual basis. Remember, medical organizations treat populations, we treat persons. Identify your patient as the unique entity that they are and treat to their own specific goal. In terms of practical pointers, please recall proactive approach of starting basal insulin, taking into consideration their hemoglobin A1C at time of start and their body weight. Please also recall that initiation is just the first step. Titration must continue to get to goal. And do not forget the 4 pillars of faith of insulin administration: preparation, initiation, titration, and continuation of support for our patients are required in order to get our patients on that path of glycemic righteousness. So we see Rajeev at 6 months after we've titrated his basal insulin to 24 units once daily. His A1C is now 7% with the fasting at goal at 108, 2-hour postprandial at 130. Rajeev feels great and looks even better on paper. So what do we do with the other medications? When basal insulin is added, the beauty is that you don't need to necessarily immediately discontinue anything. Take into consideration whether your patients are suffering from hypos. If they are and they're on a sulfonylurea, dose decrease, if not discontinue. If you're starting to see tremendous weight gain or fluid retention and they're on a thiazolidinedione, please consider dose reduction or discontinue. But aside from that, there is no overt contraindication of the oral agents in combination with basal insulin. So to summarize, recall that timely insulin therapy is necessary for type 2 diabetes patients and adequately controlled on oral agents. Please also recall that once your patients are on 2 to 3 maximally titrated oral agents, we then begin to engage in the law of diminishing returns. So adding that 3rd, 4th, 5th, 6th, 7th, etc. oral agent will give you much less than said advertised A1C reduction than as if you added that one agent by itself early in the process of diabetes as monotherapy or dual therapy. Once your patient has diabetes for 5 years or more, please consider that they may become relatively insulinopenic and it's time to start hormone replacement therapy. Once your patient is suffering from the polyps of the disease, polyuria, polydipsia, polyphagia, intentional weight loss, regardless how long or short their duration of diabetes is, regardless what their A1C is, those are signs that demand the initiation of hormone replacement therapy as insulin immediately. Please recall that insulin glargine is an ambassador insulin. It is a physiologic, convenient, effective, safe way to initiate insulin and is recommended by a variety of global guidelines. In terms of achieving that path of glycemic control, we want to do so with as little hypoglycemia as possible. And in terms of the insulin classes, basal insulin is the class that's associated with the least incidence of hypoglycemia. Numerous studies with glargine have helped to establish a basal-only therapy in combination with orals as a first-line approach to type 2 diabetes. Starting with the right dose and optimal titration can lead patients to reach goal with lower incidence of weight gain or hypo than other insulins, in particular premixes. First-generation classic premixes or second-generation co-formulation premixes are insulins that force you, condemn the patient to eat to feed the insulin on board is the antithesis of a physiologic approach, as you cannot independently titrate the two separate arms excuse me, of control. And recall that Origin trial supports long-term durability and safety of insulin glargine, reinforcing it as the gold standard basal insulin that is never too early to start. Thank you, my friends, for your kind attention.